Assalamualaikum and hi, my name is Nur Alia Amira binti Muhammad Najib. I undergo my clinical training at Bandar Metakap Health Clinic and my academic SB is Prof. Wafa, while my field SB is Madam Harashida. So today I will present about two case study, which is the first one is anemia in pregnancy and the second one is childhood obesity. So I will start with the first case study, which is anemia in pregnancy. So this is Mrs. Y. Mrs. Y is a 27 years old mother and this is her first pregnancy, which currently at 6 months of pregnancy in second trimester. She and her husband live in Kampung Haji Ali Pahang. Both of them are Malay, which graduated from secondary school. Mrs. Y is a full-time housewife, while her husband works as technician. She has moderate physical activity and she takes a cup of coffee to start her day. Okay, for case chronology, this is her first pregnancy and she claimed to have no past medical history. The current trend of her hemoglobin level was 10.5 and then 10.5. After that, dropped to 10.1 gram per deciliter. So during her 24 weeks of pregnancy, her hemoglobin HB level was at 10.1 gram per deciliter. So she was asked to refer nutritionist due to her low hemoglobin level. While for her mild anemia condition, she was prescribed with a hematinic pill, which is zinc copper, that is meant to be taken once daily. I will move on to the medical diagnosis. So anemia is one of the most frequent complications related to pregnancy. Iron deficiency anemia is most common in women who have inadequate diets and who are not receiving prenatal iron and also folate supplements. So severe anemia may have adverse effect on the mother and also the fetus. Anemia can be categorized in 4 categories, which is normal, mild anemia, moderate anemia, and also severe anemia. For medication or drugs, she was prescribed with zinc copper. So zinc copper is the first hematinic offering zinc with iron and other important hemopoietic factor. If a mild iron deficiency is present when zinc copper administration is started, this will be corrected by increased absorption of iron. So iron absorption may be inhibited if it is combined with caffeinated food or beverages such as milk, caffeine, tea or coffee. Okay, we'll move on to the nutritional assessment. For anthropometry assessment, Mrs. Y has 56 kg while her height is 157 cm and her BMI is 22.7 kg per meter square, which is in a normal BMI. For her biochemical assessment, in week 22, her HB level is 10.5 gram per deciliter. In week 23, maintain 10.5 gram per deciliter, while for week 24, the HB level dropped into 10.1 gram per deciliter. So this is the result from full blood count and she is categorized as mild anemia. For her clinical assessment, there is no medical record of sign and symptom. And then for dietary assessment, so dietary intake of Mrs. Y was assessed using 24 hours diet recall. Her dietary shown that she had a micronutrient distribution of 57.6% of carbohydrate, 14.3% of protein, and 28.1% of fat. She take moderate intake of caffeine in a day and less fruit. For environmental, Mrs. Y claimed that she cooked her own meal, but sometimes when she feels tired, she bought food from outside. She also claimed that her house is near to the supermarket. And next, for knowledge, belief, and also behavior. So she has a low knowledge on importance of iron-rich food, but she believed that food intake will influence her iron level. And she also seems like she wanted to know more about iron-rich food as she is willing to change. And then she decided to meet the nutritionist to get advice and also improve her diet. We move on to the nutritional diagnosis. Okay, based on this case, inadequate iron intake related to low consumption of iron-rich food as evidenced by hemoglobin level 10.1 gram per deciliter, which is low iron intake. Next, nutritional intervention. For the first one is cooperative standard. So for energy requirement calculation, I have Harris-Benedict equation and also quick method. Energy range for this patient is 1680 to 1760.8 kilocal per day, while for her recommended energy intake is 1680 kilocal per day plus with 280 kilocal per day as additional energy requirement during the second trimester of pregnancy. So the total energy recommended is 1960 kilocal per day. The second one is menu planning. So from the calculation, 55% of carbohydrate has been calculated, which is with exchange 11, 50% of protein, and the exchange is 5, and 30% of fat, the exchange number is 7. This is the menu for day 1, day 2, and also day 3. And the next one is the goals. For patient with anemia in pregnancy, the objective is to increase hemoglobin level above 11 gram per deciliter at 36 weeks of pregnancy. The basic principle include iron, protein, vitamin C into diet to increase iron absorption without exceeding energy requirement. And then for the intervention plan, we will introduce iron-rich food from animal and also plant source, which is with heme iron and also non-heme iron into diet, which is administered at 3 times daily during main meals. Other than that, we also incorporated vitamin C food or beverages along with the hematinic intakes to increase the iron absorption, such as patient can take zinc copper pills with fruit juice, such as orange juice or grape juice. For monitoring and evaluation, there are two aspects. The first one is anthropometry and the second one is biochemical assessment. So anthropometry is we focus to monitor weight gain. So the patient will weigh herself weekly and keep log. This is to avoid further weight gain. While for biochemical assessment, to assess patient HP level, patient will take full blood count test at the clinic and also to ensure HP level is in a normal level. We move on to the discussion. The overall iron requirement during pregnancy is significantly larger than in the non-pregnant state. Even the temporary respite from iron loss incurred during menstruation. During pregnancy, iron needs increase exponentially to meet the increased demands of fetal placenta unit, expand maternal erythrocyte mass, and compensate the iron loss at delivery. Other than that, pregnant women with iron deficiency anemia usually show various symptoms including pallor, breathlessness, hair loss, headache, cold intolerance, dizziness, and also irritability. So treatment of nutritional deficiency anemia is through a varied diet including mineral-rich food, fortified food, vitamin, and also mineral supplementation. For a conclusion, Mrs. Y has mild iron deficiency anemia during her pregnancy. She has normal weight and body mass index. Her diet intake lack of animal protein that provide or contribute to her iron level in the body. She also consumes hematinic pills together with caffeine that potentially hinders absorption of iron, thus worsening her condition. So therefore, she was put in diet modification of iron and vitamin C rich meals consisting of animal protein, green leafy vegetables and also fruit. She was also suggested to reduce and also separate her caffeine intake from hematinic pills intake at least 2 hours before meals. This is the reference. We are done with the first case study and now we are move on to the second case study, I will continue the second case study, which is childhood obesity. I will first start with her socio-demographic profile. So this is patient A. She is a 12 years old Malay girl which currently study at SK Mentakau. She and her family live in Kampung Bukit Cermin, Pahang. She has moderate physical activity and no family history of obesity. Her socio-economic profile is moderate. Her mother is full-time housewife, while her father worked as teacher. For medical diagnosis, according to WHO, obesity is defined as abnormal or excessive fat accumulation that may impair health. When energy intake is higher than the energy that is expended, it causes weight gain. For this case, the patient has unhealthy eating, which have energy dense food high in fat and sugar, and also big portion intake, plus with low activity level due to packed school schedule and also high screen time. So this condition contributed to energy imbalance and consequently causing childhood obesity. So childhood obesity is when BMI for age is greater than 2 SD above the WHO growth reference. So this is a nutritional assessment and the anthropometry data for the patient. As we can see from this graph, the BMI for this patient is above the 2 SD and she is categorized as obesity for her age. There is no biochemical data and also clinical data. While for dietary assessment, 24-hour diet recall has been assessed. From the diet recall, we can see that the calorie intake for this patient is 2077 kilocal per day, which is high calorie intake. It consists of 39.5% of carbohydrate, 18.6% of protein, and 41.8% of fats. For environmental, meal prepared by her mother at home, and her brother bring to supermarket to buy junk foods. Next, for knowledge, belief, and also behavior. Patient claim that she has no conscious control of calorie intake and portion intake due to low knowledge of weight management. But she keen to improve her lifestyle if she get enough nutritional knowledge and also guidance. And she also ready to change because she is in a preparation stage. And then nutritional diagnosis. Based on this case, excessive calorie intake related to regular consumption of high calorie dense food as evidenced by diet history of 2077 kilocal per day, which is 577 kilocal more than energy requirement. This patient has a diet high in fats. And then this is a nutritional intervention. The first one is cooperative standard. For energy requirement calculation, I have Schofield et al. And also Malaysian RNI 2017, and the energy range for this patient is 1340 and 31 to 1500 kilocal per day. The recommended energy intake is 1500 kilocal per day. For menu planning, 55% carbohydrate, which is 9 exchange, 15% of protein with 4 exchange, and 30% of fat, 6 exchange, based on menu planning for this patient. This is the menu for day 1, day 2, and also day 3. And then the third one is goal. Childhood obesity, our objective is energy intake reduction and increased physical activity. So basic principle, we will educate on energy balance and tips on how to reduce energy consumption, such as on consuming fiber-rich food to increase satiety and have lower calories. We also educate on having smaller portion size and to eat fruits. Educate on increasing appropriate physical activity according to her physical motor performance and also reduce screen time. And the intervention plan is introduce patient with fruit as snack twice daily, administer vegetable into mean meals twice daily, maintain adequate liquid intake, and also increase light physical activities such as walking around the park. I will continue with the monitoring and evaluation. There are two aspects. The first one is anthropometry, which focus on to monitor weight gain, and patient will weigh herself weekly and keep log to avoid further weight gain. The second one is dietary to assess patient dietary intake, and patient will bring 3 days diet recall for nutritionist to review, and the goal is to ensure calorie intake within the energy requirement. For discussion, childhood obesity is commonly related with energy intake and also physical activity. So in this case, we need to improve energy intake by appropriate dietary choices. This is in order to reduce consumption of calorie dense and fried food. Regular consumption of high food contributed to higher weight gain. Low-fat diet are effective to promote weight loss, and increase quality diet by increased intake of fiber such as fruit and also vegetables to increase the satiety. While for increased physical activity, we need to reduce the screen time first, and we encourage the patient to exercise at least 30 minutes per day because longer period of time may help to enhance weight loss, and consistent exercise may help to maintain weight over the long term. For the conclusion, I will conclude that it was suggested that she has to take smaller but frequent portion. The caregiver also was suggested to use healthier cooking methods such as steaming or grill, and then she is recommended to reduce her snack and sugary drinks and introduce the fiber such as fruit and vegetables as a main diet and snack and others. So considering the accelerating effect that obesity has on the worsening of health conditions such as metabolic syndrome, cancer, the family members was also encouraged to support the case daily physical activity to maximize her energy expenditure and also to reduce the nutrition intake. So this case anthropometry data were monitored closely every monthly to ensure compliance. So this is a reference for this case. That's all for two cases, which is anemia and pregnancy and also childhood obesity. Thank you.